So, sum up where we've got to now. Since the mid-1940s, we've known that it's possible to replicate the benefits. We now have a situation where about 350 million people in about 30 different countries drink water where fluoride levels are topped up. And in the UK, it's about 5.5 million, so about 10% of the British population drink fluoridated water. Mainly in the northeast and in the West Midlands, Newcastle area, the Birmingham area, some in the East Midlands, and then a number of other smaller schemes in Cheshire, Cumbria, Lincolnshire and Bedfordshire. And I'll talk about possibility of having further places fluoridated a bit later. Since fluoride was put in toothpaste, as I showed, there has been a significant reduction in caries level in children where they're not receiving fluoridated water. And so the question is, do we still need water fluoridation in the UK? And that's one of the questions which you will all have to answer when you go back to wherever you're from. What is the caries level, and do we need prevention? And if we do need prevention, what sort of prevention do we need? And one of the things you will have to consider is A, whether water fluoridation is needed, B, is it allowed within the system that you have got in your area, and is it going to be possible to do it? But even though we've got considerably better dental health in this country and worldwide in most places, there are still areas with a significant need. Areas mainly, as I've demonstrated, of social deprivation. Children in non-fluoridated Kirklees, in parts of West Yorkshire, have more than twice as many decayed, missing and filled teeth as children in Birmingham and the West Midlands. And as I've already shown, more general anaesthetics needed in those areas. And that's the problem, really. On the top left, a child with rampant caries. The upper centrals and laterals, or the upper teeth generally, shot, full of caries, and even caries in the lower teeth as well, the lower incisors. In the top right, a picture which was in the British Medical Journal a few years ago of an adult who had rampant caries, which they didn't do anything about, and you can see on that extreme right hand the result of not having treatment for caries, abscess, expanding abscess. And I have to say, if any other part of the body got that sort of disease, even the one on the left hand side, the population would be up in arms about it, but for some reason they don't really consider, often don't consider, the teeth very important. And we need to show them that you don't often get that situation on the right hand side, but it can happen if nothing is done. And rather than treatment, why not try and prevent the caries in the first place? So the benefits: less toothache, fewer extractions, fewer GAs, and I don't want to overstress it, but every time you give a child a GA, there is a risk. It's a small risk. A few years ago in the UK, we actually had legislation which prevented general anaesthetics being given in dental practices. Up till that time, dentists with appropriate training, and usually with the assistance of a consultant anaesthetist, used to give general anaesthetics. And most years there were 1 or 2 deaths of children in a dental surgery. Usually invariably really, there was some underlying medical cause that no one was aware of. The children had a heart defect or whatever it was. So you could explain why it happened. But we didn't need to give that GA in the first place. And if we're going to have to give GAs, well, what we said in Britain was it should be carried out in hospital. Doesn't totally negate all the risk. It reduces the risk and has the facilities at hand of intensive care and so on, that if anything does go wrong, you can get the child to the best place to increase the likelihood of no permanent, well, no death particularly, but no permanent health damage either. But we need to avoid general anesthesia. The most common reason for children, young children up to the age of about 5 in the UK, most common reason for them having a GA is for tooth extraction. And that's a scandal, that we are subjecting young children to that, okay, small risk, but at the very least, very unpleasant procedure. It's not nice, and it's probably going to put them off dentistry possibly for life. We are subjecting to that for a disease which could be prevented. And I think that's a scandal. So fewer GAs, fewer fillings, and from that study which I showed about the over 60-year-olds, or no, the one showing people of the various ages throughout adulthood able to keep their teeth for longer. And most people would prefer to keep their own teeth rather than have dentures. So, a lot of studies carried out. I've shown just a small number of them. But as scientists, we need to look at all the evidence. And there have been a number of reviews of the scientific literature. Some of them are what are known as expert reviews. In other words, experts in that particular area of research have gathered together all the papers, research publications on that particular topic, and they review them from their perspective of of experts in that area of research. Others are so-called systematic reviews. Sounds a bit rude, I suppose, but basically designing a review which could be carried out by chimpanzees. You set the criteria of studies which are acceptable, and then you gather them all together, and without really thinking about what they are saying, you put together all the research evidence and do statistical analysis, mega statistics, mega analysis in order to come up with an overall finding. But it's a process which does not involve so much actually looking at the details and thinking about whether the findings, for instance, are biologically plausible or not. But it is, as far as we can be, very objective. The criteria are set before you start. So although I sort of dismissed it as could be carried out by chimpanzees, of course it couldn't be carried out by chimpanzees, but it takes away the expertise of doing the brain thinking analysis of the review. But they are important. Systematic reviews actually always come out. I went to give evidence. I'll talk a bit later about the Nuffield Committee of Inquiry into Medical Ethics, and I went to talk to them about water fluoridation. And there was a professor of general medical practice there who had been involved in a number of systematic reviews. And she said they always come up with the same conclusions. They always say, whatever they're looking at, that the evidence is equivocal. We can't be definitely sure whether whatever it is they're looking at works or not. And therefore, they always say, we need to carry out more research. Now, I would say, if you ask an academic, they're going to say we need to do more research. That's how they earn their living. But that was a point she made. And the systematic review carried out by York University made very similar points. The evidence is equivocal, and we need to do more research. But they did go a bit further than that. First of all, I want to say a word or two about the quality of evidence, because one of the things that anti-fluoridationists often say is there are few, if any, studies on fluoridation carried out to the highest level of quality of evidence. What was their highest level? It had to be prospective, or at least start within 1 year of fluoridation. It had to be randomised, or if not, there had to be at least 3 confounding factors which they had taken into account, and it had to be blind. Well, it might just about be possible to do a fluoridation study which meets every one of those 3, but it's jolly difficult and exceedingly expensive. The second level, which most of the studies they looked at, where they actually met any of the criteria, were what they called moderate. Had to be prospective or start within 3 years. So there was a bit of latitude there, but they couldn't start later than that. They had to have at least 1 possible confounding factor taken into account. And if they weren't blind, that is, the examiner didn't know whether they were from the test and control area, there had to be other provisions to avoid measurement bias. And most of the studies, as I say, fell into that. And my answer to the anti-fluoridationists who say, well, most of the studies, all the studies, they say, don't meet the highest criteria. They're poor studies. They're not actually poor, they're moderate. But actually, it's virtually impossible to meet the highest. So let's be realistic. Ones that meet this are just about as good as you can get. And we can't expect more. And then there was the lowest other designs, no confounding factors, no provisions to avoid bias. Okay, fair enough, we can totally discount, but we can put those to one side and say, well, you know, we're not so sure about what they found, whether it is absolutely bang on. What did York find? So they looked at the effectiveness, and here they did find that it did prevent caries. They did a meta-analysis. They showed a statistically significant effect of water fluoridation in reducing dental caries, both as measured by the, and there's a misprint there, which I ought to put right. It should say both the little DMFT and the capital DMFT. PowerPoint seems to have changed it, and they both read lowercase, but one of those should be capital DMFT, primary teeth and permanent teeth. And also in measurement the proportion of children who are caries free, who have a DMFT of 0. And they went on and said the best available evidence suggests that fluoridation of the drinking water supplies does reduce caries prevalence. So I've just already said that. We've got the DMFT right this time. Then they said the proportion without any tooth decay is increased by 15%. Very important we recognise what that 15% is. I've been talking so far about a reduction of 50%. That's a reduction of 50% in the DMFT index. This is a reduction of 15% in the proportion of children who have some caries experience. In other words, if a non-fluoridated area, 50% of children have some caries experience. In the fluoridated area, on average, then the group of children, of that group of children, 35% will have some caries experience, 15% less. And so the anti-fluoridationists who say, oh, you always talk about 50%, it's only 15%. We're talking about chalk and cheese, we're not talking about the same thing at all. Let's get our facts right. And then they went on, children have on average 2.25 fewer teeth affected by decay. Well, yeah, that sounds very good. And well, one wishes it was true, because if you start off with a DMFT of average DMFT of 2.25 and you have fluoridation, you end up with 0. But they were using a lot of historical studies before fluoride toothpaste, some of them, when the caries levels were even higher. So that actually is artificially giving a better than result for fluoride than is reasonable nowadays. But nevertheless, they were finding a reduction, even if the figures are a bit strange. And I won't go into this in detail, but just to say, when they looked at all the various studies which met their criteria, you can see that most of them gave a benefit to fluoride. Some of them showed no statistical difference between the fluoridated area, and one actually showed more caries in the fluoridated area than non-fluoridated area. But actually, we shouldn't be terribly surprised or upset about that. People aren't like a laboratory, and they do differ, and we don't know what the difference between those two areas was. We use the 5% significance level, 95% significance level, so just by chance we would expect to find 5% of our studies falling outside what the true situation actually is. If there was no difference between the two areas, we could expect to find 5% showing there was a difference, and vice versa. I have to say that sadly one of mine was one that went across the two. But there you go. My other ones were on the right side. And the first one, I think, just to go back, that was in the proportion caries free. That is the DMFT scores. And at this time they are all actually on that side. One had a non-significant result. It was on the right-hand side.